Okay, so good morning everyone. Today we are going to uh, talk about imaging gallery of causes of bowel wall thickening. First, for the first instance, someone might say the bowel wall thickening has a lot of differential. All of them look the same, but no, not all of them look the same. There are some differences. We're going to talk about it in the following. So, first, let's see. First of all, is this real? Is there a bowel wall thickening or not? Sorry?
There is no optimal distension of the bowel.
So there is no distension of the bowel, no optimal distension of the bowel. Okay, what else? You can see that only. So is it real or not? It looks like it's not real. So the idea is that, just a second. The idea is that you sometimes the water in the bowel might simulate bowel wall distension. Ivan, it will be on YouTube, so don't worry, yani you don't need to. Okay, so there fluid in the bowel might look like a bowel wall thickening, but it's not real. You should be careful about that. The diameter, there are no signs of intestinal obstruction, no signs of air fluid levels. Of course, the clinical picture also should help you, guide you with that. There are no clinical signs and symptoms of bowel wall thickening or dilatation. Okay? So, what about this one? Is it real or not? So, there is a wall thickening here, huh? First, you can see this CT scan has a oral and IV contrast, okay? There is poor distension of the cecum, which results in simulating wall thickening. It looks like you might think there is a bowel wall thickening here. No, it's not, because the cecum is not properly distended. It's collapsed. So it gives the appearance of a bowel wall thickening. And if you look carefully, you can see something here, okay? Some edema in the subcutaneous tissue and here. And in this case, it was a bowel seat belt injury, a road traffic accident with seat belt injury. So it has nothing to do with bowel wall thickening, just an artifact. So you should keep that in mind. Before you say any bowel wall thickening, you need to have a properly distended bowel. If it is not properly distended, it's difficult to judge whether it is real or not. Okay? So, these are some of the signs related to the bowel wall thickening. What's this sign? This is target sign. Okay? What is the target sign? Explain it. Just salt. Well, here there is hypodense central, surrounded by.
Three layers. Hypodense, hyperdense, hypodense.
Exactly. And what are these layers?
The central hypodense is the lumen, hyperdense is the mucosa, and the last hyperdense is
Exactly.
the
So you have hypodense, which is the lumen, then hyperdense, which is the mucosa, then the little bit hypodense, which is the muscularis. Exactly. So there is neural stratification of small bowel. There is stratification, layers, okay? The differential diagnosis of that appearance, can anybody help us? When you see target sign, what you should think of? Intussusception, okay. What else? Portal hypertension can give you this appearance. Bowel wall edema, exactly. Infection like pseudomembranous colitis, HIV, you should keep it in mind. Acute ulcerative colitis, acute Crohn's, and don't forget typhlitis. It's a common case in the board exam. Typhlitis, especially in the ascending colon. Always keep it in mind. Any bowel wall thickening in the ascending colon, ask about history of immune problem, immune neutropenia, something like that. Okay, and ischemia, of course, it's a common cause. So, what about here? What's this sign? Excellent, accordion sign, which is a markedly thickened haustral folds. Okay, so what is the differential diagnosis of accordion sign? Pseudomembranous colitis, exactly. Alaykum salam. Okay, what else? Ischemia and non-clostridial colitis also, but usually it is due to pseudomembranous colitis, gives the accordion sign, which is the thickened haustral folds of the bowel. Okay, now what about here? What's the sign? I can't hear. Can you help?
Coin sign.
What?
Coin.
Coin? Okay, what else? Comb sign, exactly. Comb sign. What's comb sign? It's hypervascularity and engorgement of the vasa recta. The vasa recta becomes hypervascular and engorged. What's the DDX? Like Crohn's disease, lupus mesenteric vasculitis, infectious colitis. Okay. Can be used to differentiate active inflammatory conditions from lymphoma and metastasis. Lymphoma and metastasis are hypovascular, while active inflammatory conditions will cause hypervascularity. It will be vasa recta engorged and prominent. Okay? The vessels are less prominent. Okay? What do we have here? What does it called? Intestinalis, nematosis intestinalis. Okay, it is gas within the bowel wall. You can see this is the bowel wall, and you can see this is the mucosa here, and in the submucosa there are gas bubbles here and here and here. Okay, so it is a nematosis. What? Intestinalis. Okay, where do you see that? Ischemia. What else? It can be very significant and it can be non-significant. So if you see the gas reaching the portal vein there, this is a very poor prognostic sign. Okay, sometimes in patients with COPD, for example, you can see some mucosal air bubbles that have no clinical significance at all. Okay, so you should always, especially when there are some clinical suspicion, make a lung window to see the exact distribution of the gas within the bowel. Is it in the lumen? Is it in the wall? Is it extraluminal? It will make a big difference. Okay? So, what's this? You can see this is colon, and there is, what's this? This is contrast on the lumen, okay? And you can see the submucosa is thick and hypodense. It's decreased density. Due to what? Due to fatty deposition, okay? So this is called fatty halo. It is usually seen in patients with long-standing ulcerative colitis, okay? You can see increased amount of fat deposited in the submucosal layer of the bowel, okay? Now, what do you think here is going? Yalla hiba. Circumferential wall thickening. Luminal narrowing. Where? Cecum and ascending colon. Okay. You can see the wall thickening here. You can see the luminal narrowing. However, there is no evidence of bowel obstruction. You can see the bowel, it's not dilated to a significant degree, and no free fluid in this image, of course. So, what do you think is going on here? Lymphoma is a good differential diagnosis. What else? Gas. Well, gas usually presents as a mass rather than wall thickening. What else? TB. And always with TB you say? Crohn's. When you say TB in the bowel, you say Crohn's. It has to be said TB and Crohn's. Anyway, this was a case of Crohn's disease. Okay, so you should keep it in mind. It looks like lymphoma. For me, I would say lymphoma, but it was a Crohn's disease. Okay.
See, I'm giving you lymphoma is like lymphoma usually doesn't cause bowel obstruction.
Exactly. It's circumferential, it's surrounding, it's like sandwich sign, and the lumen is narrowed but no bowel obstruction, gives an appearance of lymphoma. Other possibility is Crohn's and TB. In this case, it was Crohn's. Okay? So, yalla Vana, what do you think is going on here? What? مو مشكلة يلا بان. No problem. It's المهم someone speaks. يلا continue. Bowel wall thickening. No luminal narrowing. There is diffuse concentric small bowel wall thickening with a mural stratification and narrowing of the descending colon. Okay? You can see the colon here. It's narrowed. Okay? And you can see this. Do you know what this sign called? There is a sign here. Beaded, or they call it toothpaste sign. Toothpaste sign. مثل ما المعجون الأسنان. Okay? You can see it's like a toothpaste filling this, like you, I don't know, squeeze the toothpaste and you'll have something like that. Okay? Due to what? This is represent sloughed epithelium. The epithelium of the bowel is getting sloughed. In this case, due to chronic graft versus host disease, okay, resulting in necrosis or sloughing of the mucosa of the small bowel, giving this toothpaste sign. Okay, cause appear as a diffuse concentric small bowel wall thickening with a mural stratification and luminal narrowing, but no bowel obstruction. This is small bowel, and you can see the descending colon, also some thickening in the wall and collapsed lumen. Okay? So, this is a little bit difficult one. What do you think is going on here? Yeah. Media, yalla. Describe.
Circumferential wall thickening of the sigmoid colon
Mm-hmm.
with the luminal narrowing. And
So there is sigmoid. Just a second. Sigmoid colon has a circumferential wall thickening. What else?
There is gas bubble
With a gas bubble. It's tiny one. This one,
Yes.
I think. Okay. What else?
with a little fat stranding.
Mm-hmm.
Picture suggestive of diverticulitis.
Diverticulitis. Well, it is one of the differentials, but I'll give you some information. This one is young, teenager. This patient is young. Infection. It is a sort of infection. And I'll give you another hint. It's a viral infection. Herpes. What do you want to ask if it's herpes? You have to ask something before you say it's herpes. By the way, it is herpes. Herpes simplex. But in order to pass the exam, you have to ask a question. What is it?
Manifestation and the course of the nerve, cranial nerve.
Previous history.
منين يجي herpes? From where he will get herpes? In the sigmoid.
Sexual transmitted disease.
Sexually transmitted disease. Is he a homosexual or not? This is called gay bowel syndrome. Okay? Gay bowel syndrome. This is a homosexual teenager with herpes simplex affecting the sigmoid colon. Okay? And it is type 2. Okay? Type 1 is the oral one. Okay? Now, what is this? You can see this kidney is diffusely enlarged and echogenic on the ultrasound. Okay? So that to get rid of the ultrasound. Enlarged kidney with an echogenic. What's going on the CT? Can you? Anyone? Just describe. What do you see?
There is multiple patchy hypodense lesions on the wall of the small bowel.
Patchy hypodense lesions on the wall of the
Of the descending colon.
descending colon.
And also in the cortex of kidney C.
Which,
This
no, the kidney is enlarged and echogenic. That's it. The ultrasound, leave it now. Let's talk about the CT scan. So the descending colon shows wall thickening, okay? Diffuse wall thickening, okay? With echogenic enlarged kidney, what does it equal? Yeah, the colon is involved, is abnormally thick, plus enlarged echogenic kidney. What does it equal?
Reaction to transplantation, for example.
Possible, like graft versus host disease is a possibility. What else?
disease,
Blood disease, okay. Like what?
extra hemolytic, no, cell disease.
Sickle cell? I'm not sure it has any. Tiflitis, if there is history of immune response, like we said, Dr. Rosalba said, there is graft versus host disease or something like that. What else can affect the bowel and the kidney? And by the way, it's a little bit common. Hirschsprung affect the kidney? And this is an adult, it's not a child. What? Shock bowel, okay. What? Medical? Oh, hemolytic uremic syndrome affects the bowel, and uremic affects the kidney. So there is a kidney abnormality plus bowel abnormality. In most of the cases, it will be due to hemolytic uremic syndrome. In this case, it was due to E. coli infection in a child. Okay? Only young age, not a child. Hemolytic uremic syndrome. Okay? I'm just giving you all the appearances of bowel wall thickening and due to different pathologies. Okay? What do you think is going on here? من وعدنا? Who is the nice guy? يلا فانا. فانا مو فانا. Okay? It is not so clear. Yes, I agree. Well, there is history of trauma to help you. And this is the duodenum here. So there is a duodenal hematoma. Okay? There is marked focal duodenal wall thickening. You can see this is just the patent lumen, and this all of it is a big lesion that is a hematoma. And this case was a history of trauma, whatever the type of trauma. And you can see there is some free fluid here. Okay. Also in the anterior abdominal wall, you can see some free fluid here. Okay. With this big lesion that suddenly developed after history of trauma gives you features of right duodenal hematoma. Exactly. Now who's عليكم السلام يلا بعد على الريوق jump breakfast. So what's going on here? Give you a hint. There is a history of trauma, and there are multiple arrows help you to.
This is an axial CT.
Okay, axial CT with contrast.
There is enhancement of the wall of the bowel.
Wall of the wall is showing enhancement.
Indicating there is bowel injury.
Bowel injury. Okay, what else?
Confusion. Also the right, I don't know, the right kidney also seems to be shut.
The right kidney is shattered. Exactly, lacerated.
Exciting fluid as well.
There's a fluid. The bowel wall is enhancing. And what else? What's this arrow? Why it's pointing here? Aorta, شبيل aorta. What's wrong with aorta? Small caliber aorta. And the IVC also collapsed. So overall, bowel shock or hypoperfusion complex. Small caliber aorta. The body will, the vessels will contract in order to preserve flow to significant or vital organs, like for example the brain, the heart, the kidneys, and to decrease perfusion to less vital organs like the upper and lower limbs. You might see the case he looks well or relatively well, and then suddenly he deteriorates. When the body stops being able to compensate with the hypovolemia, suddenly the patient will collapse and die. So in this case, the radiological diagnosis is of paramount importance. It's life-saving. And when the patient looks good, okay, but he's bleeding actively and the body is trying to compensate, suddenly the body will stop trying to compensate and he will crash, deteriorate. If you did not find this small caliber aorta and the hypoperfusion complex, if you didn't report it, they might not be able to do anything for the patient. Shattered kidney. Yeah. This, the, yeah, preserve blood flow to vital organs like the kidneys, the heart, and decrease blood flow to less vital organs. Okay. زين منو عندنا بعد؟ يلا ميسم. What's this? It's a very easy one. Describe.
Habitats area surrounded by thickening of the bowel.
Mm-hmm. So there is a hypodense area, this one, surrounded by a thickened bowel wall. So what does this indicate? And again, the same appearance here, طبعا, of course, the same thing here. So there is two interceptions, okay? Two. This was one and this is the other one. What would you think going on here? Why the interception? Of course, this is an adult patient. So an adult, you think of malignant cause, like lymphoma. This case was a bowel lymphoma, resulting in interception. Okay, good job, excellent. Any volunteer? ماكو volunteer؟ يلا دكتور سربست. Okay, I'll give you a hint. This is the second part of the duodenum. This lesion is in the second part of the duodenum for localization purposes. Describe. What do you see?
This is a large lobulated, thick-walled lesion.
Okay.
Seems to be a necrotic center.
Mhm.
Fluid in the center.
So there's a large lobulated lesion with a necrotic center seen in the second part of the duodenum. What else? Anything else? You can see the marked peripheral enhancement with the necrotic center. It's very obvious here and here. Thick, intense post-contrast enhancement. So, what do you think is going on? What's the difference? There's no history of trauma, by the way. Malignant GIST. This is a GIST, gastrointestinal stromal tumor. GIST. Okay?
Irregular thick of the inner wall thick mucosa.
No. This is a lesion. Space occupying lesion. This is a mass. Okay?
All its mass.
Yeah, all of it mass with big central necrosis and thick peripheral post-contrast enhancement. You can see intense post-contrast enhancement here and here due to the necrotic center. Just as a vascular tumor. It's bloody tumor. Okay?
And this enhancement in the center, this is soft tissue.
Sorry?
In the central part, there is a soft tissue, enhancing soft tissue.
Yeah, sure. It's necrotic areas with some preserved areas according to the size of the lesion. زين. يلا هبة. Okay. CT scan with oral and IV contrast.
Yes, there is circumferential wall thickening seen at the
So there is some circumferential wall thickening in the cecum here. Okay. Containing oral contrast. So. And what else? What's this?
This is a collection around the appendix.
It's like accordion
Okay, but I will give you, I will help you. It's not easy case.
This not terminal ileum. Terminal ileum and sigmoid.
This is a mass extra, يعني extra bowel, outside the bowel. Okay, extra intestinal mass that is lobulated here. Okay, and this is the cecum with a wall thickening. Do you have any idea what's going on here? So there's adjacent soft tissue mass on the right paravertebral region or right يعني so there is no history of infection or inflammation or normal white BC. White blood cells are normal. Yeah, it's not an inflammatory condition. It's a mass. Can you think of anything? Okay, I'll give you a hint. He has some cutaneous problem. This is a neurofibroma, exactly. This case very interesting. It has a neurofibroma here, big one, okay, with adjacent thickening of the cecal wall from the neurofibromatosis type 1. It's not an easy one, but it is a nice case to be seen.
This is not reactionary unit, and this is by itself.
It's a neurofibroma, type of part of neurofibromatosis type 1, okay?
And this neurofibroma.
Yes, it is a big neurofibroma, and if I have more slices, it will show it has a connection with the nerve roots and things like that.
Bowel thickening is by itself
Part of the neurofibromatosis.
Not reactionary.
No, not reactionary. Okay, but unfortunately, I don't have any other slices. So you can see the importance of history. Okay, when I said cutaneous manifestation, someone immediately says neurofibroma. Okay, we are clinical radiologists, not photographers. Okay, we need clinical information, we need history, we need examination, we need lab, we need all the things that the physician need in order to give a proper differential diagnosis and potentially save the life of the patient. Okay, the problem is that I've noticed with most of you in the board exams, we don't focus enough on the clinical history. Even sometimes we say, I give the resident, this patient is this year old, presented with this and that. He just ignore it. Okay, history. Okay.
ممكن احط differential diagnosis which we have presented Q1 and this is radiation.
Sure. If you don't have the history of neurofibromatosis, you will start giving all kinds of history. It can be lymphoma, can be metastasis, can be soft tissue tumors, can be blah, 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 whatever you like. So, can anyone give at least a description of what's going on here? No history of trauma. There is bowel wall thickening. What is kind of bowel wall thickening? Describe it in details. So there is diffuse small bowel wall thickening, okay, with a mucosal hyperenhancement all over the small bowel. Is there any signs of intestinal obstruction? It does not look dilated. There is no pathological air fluid levels, so there is no signs of intestinal obstruction, okay? So, does anyone have any idea what's going on? No trauma here. TB usually affect the ileocecal region, and it's more focal than diffuse. What else? Now we are going towards. So let's see, we are going from the common causes to the rare causes. So think rare. It's not common. Oh, sorry? Carcinoma of what? Colon carcinoma, small bowel. Mesenteric ischemia is a possibility. However, there is no nematosis intestinalis. There is no hypoperfusion in case of trauma. I told you there is no trauma. There is no blood loss. It's a good differential if there was history of trauma, but there is no trauma. This was a case of hemangiomatosis. There are diffuse hemangiomas involving the whole bowel. okay, resulting in this intense post-contrast enhancement. You can see his young age, maybe a child, I don't know, with diffuse post-contrast enhancement involving the entire small bowel due to hemangiomatosis. And by the way, I think few weeks ago we have, I'm not sure whether here or somewhere else, we have a case of multiple liver lesions with intense post-contrast enhancement, and otherwise the child was normal, and it was a case of multiple hemangiomatosis of the liver, multiple hemangiomas of the liver. So not always when you have multiple enhancing agents means tumor or metastasis. It can be something called hemangiomatosis. Keep that in mind. Okay? Now, what's going on here? Part 1, girls. Yalla. Inti. Okay, so what? Describe what you see. We are just having fun here. Describe what you see. And even there is a pointer to the abnormality. Okay, there is a diffuse concentric wall thickening seen involving the sigmoid, rectosigmoid. Well, okay. What else? You can see this rounded thing here. What's this? This is a lymph node. Okay, with an adjacent lymph node, with diffuse wall thickening of the rectosigmoid. If you do a barium enema for this patient, what would you see? No, what did they call it? The sign. No. Apple core. There will be an apple core lesion, indicating what? Adenocarcinoma, colonic adenocarcinoma. If you do a barium enema, you will see an apple core lesion, circumferential wall thickening, narrow lumen with an adjacent lymph nodes. Even if you look carefully, there might be some stranding of the adjacent fat planes, indicating a colonic adenocarcinoma. Okay, this is an apple core lesion. So you do know anatomy. Don't lie to me. Okay. يلا منو أنا this one is for Dr. Media. This is the duodenum to help you. Excellent. There is circumferential wall thickening of the duodenum. Is there any signs of intestinal obstruction? No signs of intestinal obstruction. Okay. So, what did you put as a differential diagnosis here? Infection. Okay. What else? Celiac disease is a possibility. But in celiac disease, you should see what? Duodenization of the ileum and ilealization of the duodenum. Okay? What else? Crohn's disease. Okay, but should be more distally. Duodenum is less likely to be affected. Oh, not less, less commonly affected, but it can be affected, of course. So, anyway, if I told you there is a lung problem with this guy, some respiratory problem, Langerhans cell histiocytosis. Okay, this was a case of Langerhans cell histiocytosis. Okay, which is quite good. Good job. Okay. Now, I'm just showing you all the causes of bowel wall thickening. There are a lot of things that can cause bowel wall thickening. What do you see here? Anyone? يلا هبة. صار هاي ما سامعين صوتك. Small bowel circumferential wall thickening. Okay. of
small bowel obstruction.
gaseous distension. I'm not sure if it's obstructed or not. What else? What's this pointer pointing to? See, this is the answer to the case. This pointer is the answer.
History of trauma or
No, no history of trauma.
Put the same patient.
History of chronic disease. What is this pointer pointing to? What's here? What organ is here? Kidney.
Yes.
Okay. And what does this kidney looks like?
Atrophied وبنعمل disease.
Okay. Atrophic, hypodense.
Hypodense.
So indicating, I'm giving you history of chronic disease,
Chronic
chronic renal disease. So this was a case of hypoproteinemia and chronic renal failure. Okay. So patient is edematous. The bowel wall is edematous due to the renal failure, not due to abnormality in the bowel itself. Okay. I don't know whether we should stop here or we should continue. It's already okay. Okay, we can stop here and might continue on the other session. We have around 16 more slices to see, so we can see them in another session, inshallah.
next week عندنا activity عندنا
Okay.
دكتورة